Hello everyone, and welcome to another case presentation. This case highlights the use of a biodegradable stent in the treatment of a severe biliary leak following a difficult open cholecystectomy. The patient is a 69-year-old man with a history of type 2 diabetes who was admitted to hospital a month ago with acute cholecystitis, which was treated with antibiotics. He was listed for an elective cholecystectomy and was discharged home after a few days. Unfortunately, he has now been readmitted with a 24-hour history of severe abdominal pain, nausea, and fever. On examination, he has peritonitis. The white cell count is elevated at 9.3 and the CRP is also up at 230. He has acute kidney injury with a creatinine of 189 and the liver biochemistry is deranged with an elevated alkaline phosphatase. An urgent CT scan showed acute cholecystitis, rupture of the gallbladder, abscess collection inferior to the gallbladder, and a fistula to the ascending colon. He was treated with intravenous antibiotics and taken to theatre for an urgent laparotomy. At laparotomy, the findings were in keeping with the CT scan. There was cholecystitis with empyema, a localized perforation of the gallbladder with spillage of gallstones, and an abscess cavity fistulating with the proximal ascending colon. A subtotal cholecystectomy was performed. The neck of the gallbladder was left open because the tissue was too friable for clipping. In addition, a right hemicolectomy was performed with end-to-end ileocolonic anastomosis. A single subhepatic drain, labeled A in the diagram, was inserted. In the days after surgery, the patient had increasing abdominal pain and there was high output from the subhepatic drain. Hence, another CT scan was done on day 7. This showed free fluid in the abdomen with a collection around the spleen. An anastomotic leak was suspected and the patient had a second laparotomy on day 9. At laparotomy, there was evidence of a bile leak with 3 liters of bile in the peritoneal cavity. In addition, there was a phlegmon around the ileocolonic anastomosis. The anastomosis was excised and an end ileostomy was brought out. The abdominal cavity was washed out and 2 more drains labeled B and C were inserted, one to the subhepatic space and one to the pelvis. Hence, the patient now had a total of 3 drains. Following the operation, the output from the drains remained high, totaling 600 to 700 ml per day, suggesting ongoing bile leak. Hence, on day 11, an ERCP was performed. The patient came from ITU to the endoscopy suite for the ERCP, which was performed in the supine position because the patient was too unwell to get into the standard semi-prone ERCP position. The papilla look normal. The control X-ray image shows one of the subhepatic drains. Biliary cannulation was surprisingly straightforward. The cholangiogram shows a leak from the cystic stump, and in addition there are 2 stones in the common bile duct. It is a high-grade leak because the intrahepatic ducts are not filling. Next, a biliary sphincterotomy is performed. I initially trawled the bile ducts with a 9 to 12 millimeter balloon. One of the stones proves to be rather stubborn and refuses to come out. Therefore, I change tact and try a 1.5 centimeter trapezoid basket. By jiggling the basket, I am able to capture the stone and pull it out of the common bile duct. I now go back into the duct with a 9 to 12 millimeter balloon, and after a few trawls, the duct is clear of stones on the occlusion cholangiogram. The next step is to stent the bile duct to depressurize the system and hopefully allow healing of the leak. I opt to use a biodegradable biliary stent. This is a 10 French by 8 cm Archimedes stent, which is of the slow degrading type. It maintains this integrity for about 11 weeks. The stent has a central channel and a helical construction, allowing bile to flow down the outside grooves and also through the inside channel. The first half of the stent goes into the bile duct fairly easily, but I now have some difficulty in getting the second half of the stent out of the scope. Its ridged outer surface means that the stent does not slide out as smoothly as a normal plastic stent. Eventually, with a bit of effort, by moving away from the papilla and straightening the tip of the scope, I am able to push the stent out of the scope and into the duct. If I had not performed the sphincterotomy, I could have been in some trouble, I think. After deployment of the stent, the patient returned to the ITU. This graph summarizes the output from the drains. The green line shows the total output, and the other lines show the output from the individual drains. The first laparotomy was performed on day 1. After a peak output of 700 mils on day 5, the output was beginning to settle. However, the patient needed a second laparotomy on day 9 with insertion of 2 additional drains. After the second operation, the total drain output was 600 to 700 mils per day. Hence, ERCP was performed on day 11. After ERCP, the output remained high for a few days but started to fall on day 15 and became trivial by day 18. All drains were removed by day 19. The patient is making a steady recovery and is now eating and drinking. A word or two about the Archimedes stent. There are 3 types with differing degradation times: fast, medium or slow. The fast degrading stents, which dissolve in a few days, are used mainly for pancreatic duct stenting to reduce the risk of pancreatitis. The slow degrading stents, which dissolve over several weeks, are used mainly for bile leaks and strictures. Currently, the Archimedes stents cost £635 each, compared to only £28 for a standard non-degrading plastic stent. Despite this massive price difference, the Archimedes stent is claimed to be the cheaper option because there is no need for a second ERCP to remove the stent. I hope you enjoyed this presentation. See you in the next one. Bye for now.